You see what it is on the agenda, but I decided to talk about what I want to talk about. Give me the mic.
That's why I brought him.
So I've been taking notes during the day. I want to clarify some things. Just because there's weeds in the garden, it doesn't mean they have to be treated. There are certain gardens that coexist quite well with weeds and don't necessarily require any intervention. Sometimes the weeds are there, but they're not really doing anything. Now, it's not unusual for patients to be found to have an abnormal protein in the blood, and eventually that leads to a bone marrow examination. And if the bone marrow shows less than 10% weeds, less than 10% weed infiltration, we arbitrarily say that is MGUS, and that's observation. And if you have an abnormal protein and you're symptom-free and you have over 10% weeds in the garden, then we arbitrarily say that is smoldering multiple myeloma. It's just an arbitrary definition so physicians can talk to each other, because it's silly to think that if you're 9%, you're MGUS, and you're 11%, you're smoldering multiple myeloma. But for the purposes of effective communication, we have to set a point somewhere. Now, this business about which patients do need treatment and which ones can be observed, I think one of the failures of the myeloma community is we've tried to construct a set of fixed parameters for less experienced doctors to say, if you can check this box and this box and this box, you need treatment. But I've been doing this long enough to know that a photographic snapshot of a patient at one office visit with this list of tests is absolutely insufficient to always make a decision. Now, sometimes it's very obvious. If you have a patient that has profound anemia or the kidneys are damaged, or you can see very severe bone lesions, well, those patients need treatment or they're going to suffer terrible complications. But for those who have absolutely no symptoms but have, quote, fit multiple myeloma, one has to be cautious. And what I tell my patients is that we can't make the decision on a single snapshot. We need multiple snapshots taken consecutively so we can look at the movie. And so when I have doubts about whether a person should be treated or not, I'll say, let's see what happens in 1 month. Just 1 month, we'll just see you back and see if your blood count changed or you're feeling different, or if the protein has changed. Because if the protein, which is such a reliable surrogate of what's going on, is bolt stable, even if it's high, well, then I'll say, well, let's do 1 more month. Now, of course, these patients who've been selected for observation have required a very, very advanced imaging technique that Dr. Hillengass, you can't tell a patient we're not going to treat you unless you know with absolute certainty that they don't have those white spots or those dark spots. That has to be clean as a whistle. But if it's clean as a whistle, sometimes it's not a real problem to simply monitor patients. And over the years, I've seen scores of patients who came for a second opinion after they were told, you need chemotherapy and you need a transplant, blah, blah, blah. And they had myeloma for sure, but I observed them 5, 6, 7 years, and then they needed treatment. And so most of those patients eventually do require therapy, but there's a subset of patients where it really is important to be certain. You know, before I continue, I should just say that Cato the Elder, who always, at every opportunity, said destroy Carthage, is now a candidate for Attorney General. And so I was told a long time ago that when you have any doubt about whether an individual needs treatment at diagnosis, sometimes it's better to just wait a little bit of time, as long as you're confident nothing catastrophic is going to happen, reevaluate. That isn't to say that you're never going to need treatment. That's naive. But oftentimes, treatment can be postponed, and by postponing treatment, the field's advancing pretty quickly, and then by waiting a little bit of time, the treatment at 6 months will change, and you can get the benefits of that. It's just as difficult when do you start treatment as to when do you reinitiate treatment in a patient who's relapsing. And by relapsing, I mean the proteins are rising. The proteins are going up. Patient feels absolutely fine, but you see that there's no question that the proteins are rising. And it's a much more difficult issue because we don't want to overtreat patients and exhaust what we have available when they don't exactly need it, except for there's a protein change and we know it's beginning to evolve. And again, I'm not here to give you an answer where you get a checklist, say if you have this, you need to have recurrent treatment. But there are many, many patients, because our monitoring now has become so sophisticated, we can detect a rise in the light chain, for example, or a rise in the IgG 1 to 2 years before there's any possibility of symptoms. And even with the bone marrow still looking pretty normal, we can see those changes. And so by our definitions that doctors use, if the protein's rising, it's a relapse. But just because it's a relapse doesn't mean you have to do something about it. These chemical-only, blood test-only relapses sometimes can be monitored. And you learn a lot from the movie, because the protein can rise in a number of different ways. It can rise like that. And usually that patient's going to get years before they need treatment. Or it could rise like that, where you know treatment is coming. It's imminent, but not urgent. And then there are patients whose protein will do that, in which case it looks like it's a catastrophic rise. We probably better start this week before something falls off the rails. And so it's a subtle thing. Now I mentioned you have weeds and we don't treat them. And if you're thinking about that, does that really make sense? With every other cancer, they say, screen for it, diagnose it as early as possible, treat it aggressively. A woman gets a mammogram, the mammogram shows a tumor, and I'm not saying, oh, how are you feeling? Oh, I'm feeling fine. I go, oh, I'll see you in 3 months. We don't do that. And at the time of colonoscopy, a large malignant polyp is found, and you say, how are your bowels? Fine. Oh, okay, well, we'll just watch that. So we don't do that. So where's the logical fallacy between the two diseases? Well, it's pretty straightforward, sadly. You resect the breast tumor, you cut out the colon polyp, that's cured. And to delay jeopardizes the possibility of a cure. With our types of weeds that we've been talking about for the last 6 hours, no cure. Because if there was a cure, you'd be a fool to wait and watch. Cure it, fix it, I don't have to come see you anymore. But we can't do that. And as a consequence, because we don't know how long it will take for an individual to go from I feel great to I'm not feeling great, is unpredictable. But I followed patients 15 years before they finally developed enough symptoms to intervene. And because the advances, and I like keeping my powder dry, so that when patients don't need treatment or at the time of progression, relapse, they're not symptomatic, I'm not so quick. I've got 7, 8, 10 great drugs, but they get used up. And then there's nothing left. And by just kind of sitting tight and doing nothing, sometimes I can squeeze out a little bit of extra time. And so this issue of do I need treatment at diagnosis and relapse is, just remember this movie thing. Can you check it again and see? A lot of times patients come with these very high proteins, feel great, And I say to them, well, how long have you had that protein? And they go, well, I don't know. And I go, I don't know either. And that's always a problem with newly found proteins. You see that, you don't know if someone's been walking around with that for 10 years or 10 days. And you won't know unless you do these intermittent measurements to get some sense how it's changing, because checking the test, the serum protein electrophoresis, the one that finds the abnormal protein and produces the M spike, that's not a routine screening physical exam. Nobody does that just as part of a checkup. And so these proteins can exist for quite some time before they're finally recognized. And so just a little cautionary note. I have notes before I get to my talk, actually. Oh, median survival. I hate that term. Again, when we talk about all these curves and stuff, we're really talking about averages. It's really important because those averages, I think, are very useful for interprofessional communications. Dr. McCarthy has a treatment that results in a certain median survival. Dr. Hillengas has one. I've got one. We can compare those and look at those averages. He has 100, he has 100, I have 100. Among the 100 patients, see which has the best average. But once you start drilling down to an individual patient, what does the average of 100 mean for how you are going to do? So you want to be really careful with that. And the same thing goes with staging. Dr. Reese spent a lot of time talking about staging. And I'll tell you what I think about staging. So Dr. Hillengas published an article on a myeloma treatment, and it resulted in really good results. Well, I have a different treatment, and the results were much, much better, much better. But then when we compared notes, it turned out that everyone he treated was over the age of 70, and everyone I treated was under the age of 50, and half of his patients were on kidney dialysis because of myeloma kidney failure, and none of mine were. And 2/3 of his patients were wheelchair bound due to bone pain, and mine were all walking around. So looking at raw data about his survival and my survival, what does that mean? His population cannot be compared to my population. We're treating different patients. So professional communication tries to get a stage, to get some sense of how much myeloma, how bad's the myeloma, what percent of the myeloma patients had bad genetics, and then maybe we can actually see if we're talking about apples and apples, or I'm just treating much earlier, much less sick. But when an individual, and Dr. Reese showed you these stages, they're based, and each group had 4,000 people in it. And stage 1 did better than stage 2, better than stage 3. But what happens for one patient? And they say, Doc, what stage am I? Well, I'll tell you what stage you are, but I don't know how that helps at all. I don't understand what information you get if your average at stage 3 is not as good as your average at stage 2. The average man in the United States is taller than the average woman. But if you blindly just randomly go to Times Square, blindfolded, just pick a man and a woman, you don't want to bet the house that the guy's taller than the woman. Average, you're doing fine. But when you drill down to the individual, it becomes a problem. And so looking at the curves, looking at the statistics, looking at the stage, please be cautious about over-interpreting and saying, well, this applies to me. Now, I heard a lot of stuff about transplant. Do I have to have a transplant? Well, no one has to have a transplant. Can't they just get away with chemotherapy? Well, that's probably you can. Statistics favor transplant because patients who get one have longer time without myeloma and actually better quality of life with the studies that we've done. And it's not as simple as transplant, no transplant. Because transplant certainly, I'd rather spend a couple weeks in Tahiti, I'll give you that. I mean, it makes for a really kind of a rotten month or 3 weeks. But the flip side, say, well, can't I just stay on chemotherapy? It's not like that chemotherapy is completely innocuous. So there have been a couple mentions since I've been here about the damage to the nerves in your feet. And I can't feel my feet, and my feet are numb, and I can't fall asleep at night because my feet burn, and I have to take sleeping medicines for my feet. And sometimes I have to take opioids because the burning from chemotherapy treatment was so hard on me. So, if you think about the way in which we do things traditionally, transplanted patients will get 4 cycles of chemotherapy, then the transplant. People who don't get a transplant typically get 9 cycles of chemotherapy. And I can assure you from my experience, if you get 9 cycles of the treatment, the risk of getting nerve damage is greater. And I will tell you, 3 months after a transplant, it's like you never had a transplant, except you're bald. But if you have nerve damage in your feet from chemotherapy, that's a gift for life. A lot of those do not get better. And so, hey, I avoided the transplant, and I'm going to spend the rest of my life with intractable nerve damage in my feet. So just keep in mind about, as we try to put relative values about what we try not to do and what we try to do. I'm getting there. Why is it so hard to treat myeloma? We've seen a number of slides, and they use terms like clonal evolution. Here's what it means. The myeloma that you start with is not the myeloma you end up with. You know that there's a great reluctance now in the medical community to repeatedly give antibiotics for the treatment of bladder infections, children's middle ear infections, bronchitis, colds. Do you know why they're so reluctant to give those prescriptions? I'm leaving. Who said resistance? Give them a nickel. The antibiotics engender bacterial resistance, and so if you overuse them, they become useless. Myeloma is not that much different. Let's talk about, this is a bad example, but let's say that a patient has myeloma, and actually there's 2 populations. Dr. Reese said there's 7 populations. Actually, let's say there's 2. 99% of the cells are very, very sensitive to chemo, and 1% will not be touched by chemo. I just made that up. So you give chemotherapy, whatever you give in all these treatments, and you know what? At the end of treatment, 99% of the cells are killed. You've had a 99% reduction in your tumor. Everybody's giving themselves high fives. Because look, we killed 99% of the myeloma, but what's left? That 1%, and that 1%, it didn't get killed. And Dr. Hillengass referred to that after 2 transplants. What's left? What can you kill with a third? So you have a highly resistant clone of cells, and that is the real problem we deal with myeloma, is that it keeps changing. You kill off the good ones, and they kind of get replaced by harder to kill cells. So you get a response with the first treatment, and this has been shown many times, whatever the treatment is, and the treatment lasts this long. And then with the second treatment, it's that long. And then that long. And that's why if you can not treat immediately, it may be to your advantage to have a little space. Because the truth of the matter is, it's not how much myeloma you have. It's about how resistant it is, how proliferative it is, how fast it grows. Slow-growing myeloma, you can have a lot, but it's still going to be pretty easy to treat. But if it's fast-growing, drug-resistant, even if you have a little, it's going to cause a problem. I'll start my talk now. Clinical trials. People talk a lot about clinical trials, you know. And the reality of the matter is every treatment that you're currently receiving is because you are the beneficiary of someone else who participated in a clinical trial. So here's a little known fact, even Greg doesn't know this. Honest. When my mother developed multiple myeloma, the first thing I did was said, you got to fly to Mayo Clinic and get on a clinical trial. And so my mother got lenalidomide, trade name Revlimid, in 2004. That has to be among the first couple hundred of people who actually got it. Because these clinical trials, who makes these clinical trials? You know who? The thought leaders on myeloma. These are the people who really know most about the disease, who understand what are the critical questions that they want to develop, and they're not developing them to fail. They're developing these trials so that hotshots like McCarthy can get up in front of 3,000 people and say, look at what I've done. And that's actually pretty good. It's a win-win for sure. And so if you participate in a clinical trial, it's pretty likely you're getting in on the ground floor of the best, newest therapy. And if you're randomized to the one that isn't, you're no worse off than you were. You're getting your standard of therapy. So this issue of clinical trials really is important. It benefits you, and it will benefit successive generations of myeloma patients. Are we at the point of targeted therapy for multiple myeloma? We're probably scraping the edge. One thing we probably are doing now in multiple myeloma is not targeted therapy, which I'll define, but risk-adapted therapy. You've heard a lot about genetics and testing that can be done that can define a standard risk population from a higher risk population. When I say higher risk, means the benefits of treatment probably won't last as long on average compared to 100 people who don't have the abnormality. And there are measures you can do about how rapidly the myeloma cells are growing that gives you some sense of risk. And I think in many centers now, the approach to high risk is a little bit different, a little bit. There are national trials that separate standard risk from high risk. So there are those clinical trials where in the high risk clinical trial, it's aggressive treatment, including a monoclonal antibody for newly diagnosed patients. And that isn't part of the national standard risk trial. So we're trying to get to treatment directed at risk, although there's not a 100% agreement globally about what exactly constitutes high risk. In Europe, certainly, if you have high risk in Europe, it's very likely you're going to get 2 transplants if you're transplant eligible. In the United States, that hasn't sold totally. It's probably 1. But in Europe, it's 1 transplant for standard risk, 2 transplant for high risk, unless, of course, you're from Germany, and then everybody gets 2 and you'll like it. I do think that most investigators, that when they see high-risk patients who aren't on trials, tend to use more aggressive maintenance therapy. I think that the standard in the United States nationally is lenalidomide, trade name Revlimid, for maintenance therapy. But for patients who have higher risk disease, I think there's been this movement to start adding bortezomib to maintenance, Velcade, or ixazomib to maintenance, Ninlaro, but just to do more than just give our standard of care because the outcomes aren't as good for higher. So we are making some changes in risk. Now, targeted therapy is even more nuanced, and that is targeted therapy is what Jenny talked about, a CD33 antibody for her brother's leukemia. That's targeted. And targeted treatment like that in myeloma is kind of not quite there yet, because we do use monoclonal antibodies in multiple myeloma, but they're antibodies against proteins on the myeloma cell surface that all myeloma cells have. So it's not like we're going to use this antibody for this myeloma patient, but not for this. They all get it. With one exception, a relatively new thing, and that Dr. Reese also mentioned, it's the drug venetoclax. So the trade name, I think, for that is Venclaxa. Yeah? Yeah, Würzburg. Venetoclax is this gets technical. I don't like doing technical, but there's no way to get through this. Blocks a protein called B-cell leukemia protein 2, BCL2. And that's expressed in a number of other hematologic malignancies, but it's also expressed in about 20% of myeloma patients. And there are studies underway, a couple studies have already been completed that really suggest that this is a true targeted treatment against myeloma that carries the specific T11:14 translocation. You don't need to know that, but I hope your doctor does. That would be a therapeutic option available. Other than that, we're really not quite at the targeted therapy. There have been a number of attempts to sequence the entire human genome in a myeloma patient. Whole genome sequencing, whole exome sequencing, trying to identify targets that wouldn't otherwise be thought of. Most of the studies have been disappointing, and only 15% actually have an identifiable target. So unfortunately, myeloma is not quite the same as leukemia and lymphoma in terms of the ability to find a clearly druggable target. And then finally, CAR T therapy. And I don't know where we're going with CAR T therapy. I would just tell Dr. McCarthy to show me the money. It's exciting and it needs a lot of development, but I don't think it's kind of the end game. And his conception of a triple is my kind of bunt, and you got lucky at first. A single and a triple, he wouldn't take a stand. It doesn't matter.
You can open the plane, Dr. Gertz.
I think that's all I actually wanted to say. Yeah, I'm done.